Hello, my name's Justin Andzel, and I'm going to be presenting today on implementing change with an interprofessional approach. Background of the implemented change. At a previous healthcare organization I worked for, there were changes made in the nursing administration. Previous leadership was fired. The hospital hired a new chief nursing officer, and the new chief nursing officer quickly began making changes that made the staff members I was working with very unhappy. There were cuts made to valuable resources such as nursing assistants and eliminating resource nurses who were available for assistance in patient care. Also, nurse to patient ratios were changed. Intensive care unit ICU nurses who were previously taking care of 1 to 2 patients per shift were now taking care of 2 to 3 patients per shift. Nurses working on medical surgical units who were previously providing care for 3 to 4 patients per shift saw their nurse to patient ratio increase to caring for 5 to 6 patients per shift. ICU nurses were also now expected to float to floors on a regular basis and take care of a full medical surgical assignment. Previously, ICU nurses were rarely asked to float out of the ICU. Additionally, charge nurses began taking patient care assignments on top of their charge nurse duties. Charge nurses previously did not have patient care assignments and could put all of their focus on leading the unit, keeping order, and providing an extra set of hands in emergent situations. Rationale for change. From my understanding, these changes were made by nursing administration for financial initiatives. The departmental cuts increase in nurse to patient ratio, asking ICU nurses to frequently float to the floors. Having charge nurses take patient care assignments, all were actions taken to lower the labor cost and address nursing staffing shortages in the medical surgical units and progressive care units. From an economic standpoint, it appears that cutting resources like nursing assistants and resource nurses, increasing nurse to patient ratio, and having charge nurses take assignments would decrease the cost of labor and help the hospital save money. But the truth is, having adequate staffing and resources leads to improved quality of patient care, less mistakes made, improved workplace environment, improved staff morale, improved patient outcomes, decreased cost of care, decreased length of stay for patients, and decreased number of hospital-acquired infections. In the scholarly nursing journal MedCare, an observational research study was performed to analyze the effects of adequate nurse staffing in a hospital setting. It was determined that staffing nursing units adequately increases patient safety and improves the quality of care delivered. The research also determined that improved hospital nurse staffing leads to saving thousands of lives per year, and that the associated cost of increased nursing staffing would be offset by drastic savings from reduced hospital readmissions and length of hospital stays. The author also notes that this study informs nursing administration, hospital administrators, and policymakers on the importance that adequate staffing makes on the well-being of the hospital and healthcare organization. The departmental cuts increase the nurse to patient ratios, asking ICU nurses to frequently float to the floors, and having charge nurse take patient care assignments all were changes that decreased nurse morale. Many nurses began looking for other jobs and ended up leaving. Nurses were being overworked and feeling burnt out with the newly implemented changes. With increased nurse to patient ratios and fewer resources available, nurses felt they were constantly being put in unsafe situations, and the quality of patient care was decreasing, and patients were having lengthier hospital stays and worse outcomes. Due to the unsafe environment and increased workload, staff turnover rates became very high. Leadership was forced to hire more nurses and bring on travel nurses to fill their staffing shortage gaps. Ethics, legal, and political implications. From an ethical standpoint, it is completely unethical for hospitals to push an agenda where saving money is a priority over safe staffing levels and a healthy workplace environment. As stated, unsafe staffing levels lead to decreased quality of care and worse patient outcomes. Legal implications of making cuts to nursing resources and increasing nurse to patient ratios is that nursing staff is placed at a higher risk of making more mistakes, constantly put in unsafe situations, have increased liability, increased potential for negligence claims, and increased moral distress due to increased workloads with fewer resources and the inability to provide high quality patient care. According to a publication by the National Nurses United, research illustrates that when nurses are demanded to care for too many patients at once, patients are at an increased risk for preventable medical errors, avoidable complications, falls, hospital-acquired infections, increased length of stay, increased cost, and increased mortality rates. Staffing adequately for safe nurse-to-patient ratios has been a political issue debated upon within the healthcare industry for quite some time. Political implications of nursing administration implementing increased nurse-to-patient ratios is that safe staffing bills are currently being presented to Congress to mandate safe staffing ratios in hospitals across the country to protect both nurses and patients. Advanced practice registered nurses' role as change agents. Advanced practice registered nurses, APRNs, play a significant role as change agents within the interprofessional and healthcare teams by identifying problems, leading evidence-based quality improvement projects, and implementing new systems and practices to improve the quality, safety, and efficiency of patient care and improve patient outcomes. APRNs also utilize their advanced education and skills in leadership, coordination of care, communication, and critical thinking to advocate for changes, innovation, provide continued education to interprofessional team members, and overcome unsafe practices or policies. APRNs act in a leadership role within the interprofessional care team by advocating for and communicating the need for change. APRNs act as change agents by leading quality improvement projects and initiatives, utilizing best evidence-based practice to improve the quality of care, the efficiency of care, decrease cost, improve patient safety and outcomes. APRNs also act as change agents by helping lead and coordinate interprofessional collaboration and communication among the interdisciplinary care team. APRNs also help in resolving conflict between nurses and administration by utilizing their ethical leadership ability, knowledge, and the communication skills to promote resolution. APRNs also act as change agents by constantly providing education to the nursing staff, interdisciplinary team members, patients, and their family members, enabling them to participate in the plan and problem solve to improve the systems and quality, efficiency, and safety of the healthcare. APRNs can also play a significant role as change agents. The changes that the nursing administration implemented at my previous employer included a reduction in the number of resource nurses, nursing assistants, and unit secretaries, increased nurse-to-patient ratios, and charge nurses having to take patient assignments. APRNs could help combat such a dilemma by leading evidence-based quality improvement initiatives that illustrate that safe nurse-to-patient ratios lead to improved workplace environment, decreased staff turnover, improved quality of care, increased patient safety, decreased length of stay, decrease in cost of care, decrease in hospital-acquired infections, decrease in falls, improved patient outcomes. APRNs could resolve the staffing and nurse-to-patient ratio crisis and facilitate resolution between nurses and administration by utilizing their ethical leadership ability, knowledge, communication skills to advocate and present the evidence from research that safe nurse-to-patient ratios lead to improved quality of care, improved patient outcomes, and more efficient care. Interprofessional stakeholders' involvement in change efforts. Interprofessional internal stakeholders include registered nurses, clinical nurse specialists, clinical nurse educators, nurse managers, nurse leaders, nurse administrators, hospital administrators, nurse practitioners, physician assistants, and physicians. Interprofessional external stakeholders include policymakers, government officials, and union organizations, professional organizations such as the American Nurses Association, ANA, American Association of Critical Care Nurses, AACN, National Nurses United, NNU, the American Organization for Nursing Leadership, AONL, are organizations that advocate for improved nurse-to-patient ratios. Professional organizations' role. These professional organizations use various methods to advocate for and promote safe staffing levels, improve patient outcomes, and nurse well-being, including one method they use is lobbying to demand for state and federal legislation that will mandate safe nurse-to-patient ratios and overall staffing levels. Another method these organizations are using is creating and publishing policy statements that present official stances on recommendations for safe nurse-to-patient ratios to healthcare leaders and policymakers. Another method professional organizations utilize to advocate for appropriate staffing levels and safe nurse-to-patient ratios include developing professional standards and guidance documents to assist healthcare facilities in implementing and maintaining optimal staffing levels and increasing public awareness through campaigns, publications, and rallies to shine light on the detrimental effects of unsafe staffing and patient ratios. The American Nurses Association, ANA, their statement on staffing, safe staffing is ANA supports a legislative model incorporating nurse-driven staffing committees because this approach encourages flexible staffing levels. At least 55% of staffing committee members should be direct care nurses. The American Association of Critical Care, their statement on safe staffing is a longtime champion for appropriate staffing in acute and critical care settings and offers specific standards and resources to improve staffing challenges in these areas. Change theory model for exceptional results. Kurt Lewin's three-step change model can be utilized to implement adequate staffing levels and safe nurse-to-patient ratios. Lewin's model can be used to manage change and guide the healthcare organization through the necessary steps of preparation for the change, implementation of the change, and reinforcement of the change. Lewin's model consists of 3 steps. Step 1 involves unfreezing the organization by bringing awareness of the need for change. Step 2 is the freezing phase, where the change is implemented. Step 3 is the refreezing phase, where the change is solidified into the culture. Lewin's model is an effective model to use for implementing change in a hospital's unsafe nurse-to-patient ratio. The ratio is an inadequate staffing and resources because its 3 stages, unfreezing, changing, and freezing, provide a simple, structured framework to manage resistance to the desired plan to implement safe nurse-to-patient ratios and create a lasting change in the culture where patient safety, staff well-being, and optimal patient outcomes are the gold standard. Ethical, social, legal, economic, and political implications of using Lewin's change model. Ethical implications of using Lewin's change model to implement changes creating safe staffing and nurse-to-patient ratio include the likelihood that disequilibrium will take place during the unfreezing phase when the unsafe staffing ratios are challenged and change is advocated for. It is essential to utilize open, honest, transparent communication and continuously educate those involved during the unfreezing phase to attain stakeholder support and provide an understanding of why the changes are necessary. One social implication of using Lewin's change model to change the unsafe nurse-to-patient ratios is that it may cause conflict, tension, and resistance between the nursing staff, nursing administration. During the first phase, the unfreezing stage, it is essential to make those involved aware of the flaws in the current unsafe practices of inadequate staffing that are leading to poor quality of patient care, poor patient outcomes, and decreased staff morale. Challenging nursing administration to see the inadequacies in the current practice and need to allocate more sufficient staffing and resources to patient care can cause tensions to rise. In dealing with increased tension, it is first important to remember that resistance to change in nursing is likely based on fear, uncertainty, doubt, frustration, distrust, confusion, and anger. To manage resistance and increase tension, it is essential to show empathy to staff, build trust, utilize active listening, and acknowledge the concerns with current unsafe staffing and nurse-to-patient ratios. Also, resistance can be managed by thoroughly communicating and presenting the concerns of the current unsafe nurse-to-patient ratios to administration, utilizing evidence-based research, illustrating the data of how insufficient staff leads to worse patient outcomes, decreased quality of care, increased staff turnover, and decreased staff morale. Legal implications of implementing changes to the unsafe nurse-to-patient ratios and inadequate staffing and resources is that all hospitals have a legal obligation to provide high-quality care to sick patients. Inadequate staffing levels and increased nurse-to-patient ratios lead to a decreased quality in patient care, increased workloads, increased errors, hospital-acquired infections, and falls, which can potentially lead to civil lawsuits and medical negligence cases. It is important to create a sense of urgency in the unfreezing stage for the hospital to make changes and implement safer nurse-to-patient ratios to improve quality of care, patient outcomes, and to decrease the likelihood of errors and legal liability. Economic implications of initiating changes to improve staffing and nurse-to-patient ratios is that initially it will cost money to hire and train additional staff nurses and temporary travel nurses. Another economic implication is that the process of improving staffing, resources, and nurse-to-patient ratios is taxing on management and administration and requires adjustments of departmental budgets, reallocation of resources, and dealing with the change process. To manage the negative economic implications of increased cost to hire and challenges with the budget, it is important to use effective communication to place focus on the long-term effects of improving staffing and nurse-to-patient ratios, such as improved quality of care and patient outcomes, decreased length of hospital stay, which leads to cost saving and more open beds and ability to admit patients, improve staff morale, lower levels of burnout, decrease staff turnover, which saves money in hiring and training new nurses, decrease hospital-acquired infections and falls, improve patient satisfaction, and enhanced reputation as an institution. One political implication of initiating changes to improve staffing and nurse-to-patient ratios is that powerful stakeholders such as hospital administrators tend to view improvements in nurse-to-patient ratios as a financial burden that increases operational cost and resists such proposals for change. To combat the political resistance of powerful stakeholders, it is important to create a committee composed of registered nurses and stakeholders, which has a central focus of improving the nurse-to-patient ratios and advocacy for adequate staffing. The committee can focus on addressing safe staffing by initially making small changes such as improvement in nurse-to-patient ratios on high acuity units and working on improving staffing one unit at a time. APRN initiating the change. Lewin's model, step 1, unfreezing. As a future APRN and change agent, in order to utilize Lewin's change model to implement a culture where adequate staffing levels and safe nurse-to-patient ratios are accepted and promoted in the unfreezing stage, I would first have to raise awareness on the detrimental effects of the current insufficient staffing levels, such as decreased quality of care, increased cost of care, increased length of stay, worse patient and outcomes, and increased mortality rates, increased hospital-acquired infections, increased staff burnout and turnover. It would be important to include all stakeholders involved in the education and awareness process. I would also educate all stakeholders involved on the positive effects of the evidence-based research, reflecting that improved nurse-to-patient ratios lead to improved quality of care and patient outcomes, decreased length of hospital stay, improved staff morale, lower levels of burnout, decreased staff turnover, decreased hospital-acquired infections and falls, improved patient satisfaction, and enhanced reputation as an institution, along with raising awareness and educating stakeholders on the current staffing crisis and how things need to be changed to improve patient safety, outcomes, and improve staff well-being. I would create a sense of urgency by sharing data and statistics on the current levels of staff burnout, turnover rates, poor patient outcomes, increased hospital-acquired infections, falls, and safety events to illustrate that the need for adequate nurse-to-patient ratios and staffing levels is serious. I would also attempt to challenge the nursing administration to see the inadequacies in current practices and need to allocate more sufficient staffing and resources to patient care to improve the quality of healthcare delivered, improve patient outcomes, and improve the well-being of staff. APRN initiating the change. Lewin's model, step 2, implementing the change. As a future APRN and change agent and utilizing Lewin's change model to implement a culture where adequate staffing levels and safe nurse-to-patient ratios are accepted and promoted. I would move on to stage 2, or the change phase. In this phase, I would implement the newly established nurse-to-patient staffing policies. During the phase, the emphasis would be on recruiting and hiring more permanent staff nurses, temporarily bringing on travel nurses to fill the staffing gaps, and offering overtime for current staff to meet the staffing standards of the newly designed nurse-to-patient ratios. I would also provide additional training and education to nurses so that they can be cross-trained to work in different departments and pick up additional shifts to meet adequate staffing levels. During the change stage, it is essential that clear, transparent, open communication is used to all stakeholders and staff members to offer support, hear concerns, and make adjustments as necessary. APRNs initiating the change. Lewin's model, step 3, refreezing. As a future APRN and change agent, in utilizing Lewin's change model to implement a culture where adequate staffing levels and safe nurse-to-patient ratios are accepted and promoted, I would move on to stage 3, or the refreezing phase. In the final phase, emphasis would be on integration of newly developed nurse-to-patient ratios and safe staffing matrices into an official hospital policy. This would allow the new nurse-to-patient ratios and staffing matrices to become a permanent part of the hospital culture and expectation to be followed without exception. During the refreezing phase, it would be important to continue to monitor and evaluate the effects of improved staffing and nurse-to-patient ratios. It would also be essential to evaluate data on staff morale, staff turnover rates, patient outcomes, hospital-acquired infections, and safety events to make sure the desired outcomes are being achieved. Lastly, it would be essential to seek feedback and insight from staff members on the effects of the implemented staffing changes and nurse-to-patient ratios. Based on the feedback, there may need to be some modifications made. Ultimately, during the final phase, it is essential to continue to instill the standard of adequate nurse-to-patient ratios and staffing levels into the hospital culture as a gold standard of high-quality, safe patient care with promotion of the best possible outcomes for patients and optimal well-being for staff members. Impact on the organization if the change initiative is unsuccessful. If the change initiative to implement adequate staffing and safe nurse-to-patient ratios is unsuccessful, there will be consequences within the healthcare organization. Staff morale will be low as the hope for improved staffing will feel out of reach. Staff may experience change fatigue, leading them to be disengaged. Low morale will likely lead to staff burnout and increased turnover. Staff members will also lose faith and trust in the leadership's ability to guide the organization successfully. As the result of an unsuccessful implementation of adequate safe staffing and improved nurse-to-patient ratios, the quality of care will continue to be decreased. Unsafe practices and mistakes will continue to take place. Patients will experience worse outcomes, and the reputation of the healthcare organization will suffer. Steps the interprofessional team can take if the change is unsuccessful. If the change initiative to implement adequate staffing and safe nurse-to-patient ratios is unsuccessful, the interprofessional team can take steps to address the failure. First, the interprofessional team needs to evaluate what went wrong in the process. Next, the interprofessional team must perform a comprehensive review to achieve an understanding of why the implementation of safe staffing and nurse-to-patient ratios was unsuccessful. In this process, it will be essential to collect and evaluate the data and sound evidence to determine the causes of the failure. The interprofessional team will also need to gather feedback from staff members to identify challenges they experienced and determine what could have been made the change more successful. The interprofessional team also must determine barriers and assess if insufficient resources, finances, ineffective communication, and training were a factor in the failure. After a comprehensive review of what went wrong, evaluating the flaws and barriers, speaking to staff and receiving feedback, evaluating the evidence and data, the interprofessional team can create a new vision for change. It is essential that the vision is clear and goal-oriented, and emphasis is placed on the importance of improving the quality of patient care, patient outcomes, and staff well-being. It is also important that all staff members and stakeholders involved in the change process become come to an agreement on the potential barriers and challenges they may face and improvements that can be made to make the change successful. It will also be imperative to ensure that communication to the staff is clear, open, and honest and transparent about the vision for new changes and strategies that will be implemented to achieve it. The interprofessional team can also promote a culture of empathy, understanding, collaboration, open communication, and shared goals to rebuild trust and achieve organizational harmony. Additional factors driving organizational change and the APRN's role as change agent. One factor that will drive organizational change will include increased focus on high-quality patient-centered care, care coordination, and quality improvement. Emphasis will be on value-based purchasing and care. In this framework, hospitals will be compensated for the quality of care provided, efficiency, cost reduction, patient outcomes, patient experience, avoidance of hospital-acquired infections, patient safety, and adherence to best clinical practices, policy, and procedures. Value-based care models reward hospitals for improved quality of care and improved patient outcomes, which makes an APRN's role as change agent essential in achieving these goals. The transition to a focus on value-based care will require a commitment from APRNs to establish a new status quo or refreezing when approaching and delivering patient care. APRN's role as change agent will be essential not only for improving the quality of patient care, but also in collaboration with the interdisciplinary team and supporting staff. APRN's role as a change agent in value-based care will also focus on advocating for innovation, leading practice changes in quality improvement projects, and improving the quality and efficiency of patient-centered care. APRN's role as change agents will involve a personal commitment to transforming practice, collaborating with the interdisciplinary and interprofessional teams, positively influencing patient outcomes, increasing the efficiency of care, decreasing hospital cost, and enhancing the healthcare delivery process. Transformational leadership style is the preferred leadership approach for APRNs to lead change in healthcare organizations to increase the quality of care delivered, decrease cost, improve efficiency, decrease adverse effects, improve the workplace environment, improve patient satisfaction, and improve overall patient outcomes. These are my references. Thank you for listening to my presentation.